Hello and welcome to today's webinar, Practical Strategies to Engage Physicians, a Case-Based Approach. I would now like to turn today's call over to Leanne Myers, Chief Clinical Officer of PerfectServe. Leanne, please go ahead.
Great. Thank you, Jennifer, for opening up the webinar for us. Hello, everyone, and thank you for joining us on this Tuesday afternoon. PerfectServe is pleased to sponsor today's educational webinar entitled Practical Strategies to Engage Physicians, a Case-Based Approach. For those of you who may not be familiar with PerfectServe, PerfectServe is the industry's only comprehensive and secure communications platform that unites clinicians across the care continuum. More than 45,000 physicians across the country rely on PerfectServe's cloud-based communications system that routes voice, text, web, and system-generated communications. Whether you're part of a solo medical practice or a world-class health system, PerfectServe can help you drive meaningful improvement in your care delivery processes. And for those of you who regularly join our thought leadership webinars, many of our webinars focus on education and knowledge sharing. Today's topic is physician engagement. This afternoon, I'm very pleased to have Dr. Ken Cohn on the line with us today. He's calling in from the snowy Northeast. Dr. Cohn is an expert on physician management and collaboration. He is a board-certified general surgeon who speaks, consults, writes, and teaches. He is well-published with 51 articles in peer-reviewed medical journals and 4 books. Dr. Cohn is internationally recognized thought leader in physician-hospital relations and is currently CEO of Healthcare Collaboration. Dr. Cohn, thank you so much for joining us today, and I will turn things over to you.
Thanks, Leanne. It's a pleasure to be here. And our first poll is, how engaged are your physicians? Please mark down whether they're not engaged, beginning to be engaged, consistently engaged, or extremely engaged. And while you're doing that, I will go to the overview. To be on the same wavelength, I'll define what I mean by physician engagement. Then we'll talk about why it's important, and then we'll have 4 different case presentations that show other aspects of physician engagement. Physician engagement is easier to pronounce than it is to achieve because of the double meaning. It could be a promise, as in engaged to be married, and also signify a battle, as in engaging the enemy. Hopefully, it reflects the pride, loyalty, and commitment to a shared mission, vision, and value, as defined on the next slide, operationally. And it looks like before we go to the next slide, we have our poll results, which show 18% are not engaged, 59% are in the early stages of engagement, 14% are consistently engaged, and 5% extremely engaged. So really only about a fifth of the physicians are consistently or fully engaged. And that shows both the challenge and an opportunity to improve for the future. According to the advisory board, engaged workers strongly agree that their organization inspires the best in them, that they are willing to put in a great deal of effort beyond what is expected, and that they talk up their organizations to friends as a great place to work for. Gallup did some work on physician engagement and found that physicians who were engaged were 26% more productive than physicians who were not engaged, and that was reflected in an average of about $460,000 increased patient revenue per physician per year, which shows the value of investing in physician engagement. What are the top elements of physician engagement? This is according to a poll of physicians, over 1,600 of them, And first was respect. The second was a feeling that their opinions are valued. The third involved good relationships with their colleagues. Fourth involved a good work-life balance. And then the fifth involved a voice in how their time was structured and used. On the other hand, they also mentioned some variability. And within the battle image that we described previously, several physicians defined engagement as what administrators cite when they want something, usually for free. So on that note, let's go to the next slide and the first case. And here was a hospital on the West Coast that had to build a new hospital and yet didn't know what services to include. In the past, ambulatory surgical clinic was built, which siphoned $5 million a year out of their revenues. The GI docs and the pain docs had moved off campus, which siphoned additional money. And the hospitalist movement freed the primary care docs from having to come into the hospital except for social reasons. And so the whole referral basis on which the subspecialists depended was at stake. And finally, when they discussed call pay, and one of the physicians who sat on the board discussed the slippery slope, a general surgeon challenged him by telling him, "You're nothing but a hospital whore." So in that case, what would you do given the above situation to plan for the new hospital? Why don't you just jot down your thoughts over the next 30 seconds or so? And the only answer that's not permitted is to call in an outside consultant. And as we discuss what it is that this hospital did, I want to say that the doctors at this hospital were very much dead set against top-down initiatives. They wanted to do something by themselves. And so here's what they did. They engaged in a situation where the CEO appointed 2 doctors to be medical advisory panel co-chairs. They then appointed 13 other members who were clinical champions, just like they were, people who were well respected in their field. These people then appointed presenters from all the major sections and departments to give both a written and an oral report to the panel, which they then compiled into prioritized recommendations. And these recommendations were presented not only to the hospital and the board of trustees, but also to doctors within their medical staff. And the following slide displays the results of the first year. They saved over $5 million over 6 years by consolidating vendors in orthopedics. Over 250 patients are alive as a result of progress made in improving treatment of people with overwhelming infection, otherwise known as sepsis. An operating room that had problems with throughput eventually won a national award. They developed a new stroke care center for their population that cares for over 300 patients per year. And the most long-lasting result was that they trained a whole bunch of leaders who may not have been clearly identified previously. And as a result, they've had no trouble finding candidates to be president, vice president, and secretary of their medical executive committee. The fact that it's ongoing and sustainable comes from the information that last year over $6.2 million in savings were generated by physician administrative dyads, and over half of that had to do with decrease in physician preference items. Here are some words from one of the participants who prided himself that he hadn't been on a hospital committee for over 2 decades. he said that the hospital had to undergo a cultural enema, in his mind, meaning that the processes needed to become more timely and transparent. Yet he enjoyed these data-driven presentations with his colleagues and obtained a new perspective of the complexity of hospital relations. Continuing his thoughts, he evolved in his perspective, as did other physicians, from what the hospital should do for us to how they could improve care for their patients. He became an owner rather than a renter, and he felt the reason for the change in outlook is that he felt he was making his time count. So to summarize what we learned from this case, we can facilitate bottom-up cultural innovation by engaging physicians in data-driven collegial processes that make their time count and help them leave a lasting legacy. What are the steps that are involved in building a culture of collaboration? First, to engage the top clinicians, regardless of how difficult it is to get along with them. If you only have the get-along gang, you lose all credibility with the physicians. Second, doctors don't learn process skills in medical school, residency, or fellowship, so it may be necessary to give them those process skills going forward. Third, to focus not only on the problems, but also develop some appreciative inquiry of past successes to transcend silos and achieve outstanding results. And four, to recognize that the status quo is a decision. Fifth, to visualize these tangible benefits of improved processes that come from developing a shared vision for the future. Sixth, to get rid of unnecessary steps. And one example came in Indianapolis, Indiana, where 6 different chief medical officers got together and removed over 23 steps to improve the administration of insulin to diabetics, resulting in improved outcomes and decreased cost. Seventh, work on quick wins, and these don't need to cost a lot of money. In this hospital in California, there were things like making sure that the obstetricians had clean linen in their on-call room, and the anesthesiologists who complained that there was no place to park when they got called in at night had a parking space right next to the hospital with orange cones marking it for no parking, and only they knew that they could move the orange cones. 8, to celebrate success. Jack Welch, when he was president and CEO of General Electric, said he never missed an opportunity to celebrate, and I think that should be true here as well. By getting people together to celebrate good results, you may have some communication that prevents the next crisis from happening. 9, because doctors tend to view long-term as fairly specific in terms of days, to chunk longer-term tasks into a series of measures that have deadlines of no more than 2 to 3 weeks. And this is a way to build trust by improving transparency. 10, understand that this process is a lifetime journey and not a destination. The pitfalls to avoid are getting stuck in doing things the same way over and over and over again. Being impatient with building consensus as one tries to build a sense of shared vision and shared ownership. Unwillingness or inability to implement solutions in a timely fashion, and then needing to be in control. One physician said it took him most of his life to recognize that he gained a lot more influence by relinquishing just a little bit of control. And now it's time for our second case study. This involved a cardiac catheterization medical director in New England who faced the closing of a procedure room because the proliferation of supplies had gotten so great that either they had to figure out a solution or they would have to make another room a storage room. And he knew what the variability in costs and procedure time and clinical outcomes was among his 6 cardiologists, and there were no real differences. And so the question is, why don't you spend 30 seconds and figure out what would you do? And as I say, every solution is possible and permitted except calling in an outside consultant. And here's what they did. He encouraged his doctors as he presented the results in bar graphs with cardiologist A, B, C, D, E, and F, in other words, anonymously displayed, to come to some sort of consensus over the next 6 months. Otherwise, what he said is he would put the names over each cardiologist's name, and he'd post the results in the cardiac catheterization lab for everybody to look at and make suggestions. And what happened is within 4 months, the costs and the times and the outcomes were all within one standard deviation because, as one of the cardiologists said, none of us wanted to be an outlier except on the positive side. This works not only in cardiology, but also it works within medicine. And here was a group of primary care practitioners, both primary care doctors and mid-level practitioners, who wanted to be part of an insurance group to compete for a managed care contract, patients with diabetes. Each provider's name was displayed on a boat that was marked on a chart in the waiting room with start and finish times. And each time they put something down according to the third bullet, the boat advanced. By the end of the year, less than 3 months after they introduced this little contest, all providers, that's over 200 of them, were in full compliance with core measures, and they won the managed care contract. So what we can learn from this case is that whenever you hear the idea, this feels like herding cats, use healthy competition to help the doctors align their efforts so that they don't become negative outliers. Allow them to feel like Lake Wobegon, that they're all above average. The third case study involves a chief of urology who was very excited about an idea which he thought would decrease the time for going from development of a prostate nodule to knowing what the treatment plan was going to be. And the COO dismissed him with, "Fine, go write me a business plan." And he turned to me, and over the course of the summer, every Thursday, we would meet at a restaurant and work on a business plan. By the end of the summer, this business plan not only became the blueprint for the urology improvement, but also for a multidisciplinary cancer diagnosis and treatment center, as well as a digestive disease diagnosis and treatment center. So it just goes to show that doctors can write business plans as long as you start focusing on first things first and not get all involved in the finances, which is what scares most doctors off. So I'd like to ask, how many of you have written a business plan? And we'll start the polling now. And while we're waiting for those results to come in, I'd like to explain that the reason for writing a business plan is to get clarity on what it is that one plans to do. And that helps attract resources that are necessary for success. And anyone who would like this article about engaging physicians in business plan is welcome to obtain it by sending me an email note, and I'd be happy to send them a PDF of this article within the next 2 or 3 weeks. You'll be able to find my email address at the end of this presentation. So what was in this business plan that I helped this physician write? The first thing was an executive summary of the entire business plan on one page. The idea of creating a good first impression, that this doctor had done his homework and knew what he was talking about. The business concept showcases the unmet needs, sort of what we call the potholes in the road and the reason for paving them. The market analysis shows the patients who can benefit from the new service, and the competitive analysis shows the alternatives, such as, in addition to surgery, for this doctor, involved radiation therapy and chemotherapy, and also not doing anything, watchful waiting. Out of this market analysis and competitive analysis comes the business strategy, which is the unique value proposition which answers the question, why should we do business this way, or why should someone do business with you? The financial plan involves both calculation of revenues and expenses, as well as cash flow. And the operation plan showcases the people, the space, and the equipment necessary to get the job done. The implementation plan shows not only the task, the person, the timeline, but all the things that are necessary to deliver this service on time and within budget. So the lesson of this case is that doctors can contribute to business planning, especially if we begin with questions that they can answer, such as which patients will benefit from this innovation? What are the alternatives? And what and whom do you need to deliver this innovation in a timely fashion? And once one develops rapport with a physician, one might even ask, who are some grateful patients of yours who might want to contribute to this process? Before we go on to the next case, it looks like 56 of you have written a business plan and 44% have not. So a lot of people in the audience are familiar with writing business plans, which is great. As we look to a strategic approach for physician engagement, obviously the first thing is to know our marketplace and the challenges and what we call the SWOT analysis, the strengths, the weaknesses, opportunities, and threats. Clearly, it's important to reach out to physicians and articulate shared vision, mission, and values. The other thing that's important is to leverage resources in support of improvement initiatives and verify worker engagement through the questions that we raised earlier from the advisory board, that this organization really inspires the best in me. I'm willing to put in a great deal of effort beyond what is normally expected to help this organization be successful, and I brag about this organization to my friends as a great organization to work for. The last point about the compact is what we'll explore in the next several slides. And this last case involved Wheaton Franciscan, which was a group of several hundred physicians who needed collaboration to achieve their goals and wanted to promote value-based behaviors among their physicians and mid-level providers. They recognized that this was a social and not a legal contract that hinged on mutual respect and understanding, and described their vision and values in a way that reaffirmed core principles of interdependence and collaboration. The methodology is displayed here to show that this is a bottom-up process, and the process in which it was talked through among a variety of different departments was just as important as the words that went into it. They feel there was no coincidence that 2 years after the compact was signed that they were listed as a Thompson 100 top care group. The reaction among providers was initial skepticism, but as one of them said, he realized it's a great place to start in addressing the mission and the goals of the organization, and he said it makes the expectations crystal clear in his mind. So we'll talk about Wheaton Franciscan as the first example of a compact. And under respect, basically the hospital administrators promise to actively listen, communicate, share ideas, and support physicians, and create a working environment that is open, trusting, respectful, and fulfilling. Whereas the doctors promise to treat every patient, colleague, and associate of Wheaton Franciscan with respect, dignity, and compassion, actively support the organizational and group goals, and actively listen, share ideas, and communicate. Gundersen Lutheran is another Midwest healthcare system, and under the Achieve Excellence, the hospital plan promises to recruit and retain outstanding physicians and staff, support career development and enhance professional satisfaction, and create opportunities to participate in quality improvement, research, and improvements in community health. Whereas the doctors, in focusing on superior patient care, agree to practice evidence-based high-quality medicine, encourage increased patient understanding, involvement in care and treatment decisions, and achieve and maintain optimal patient access. Virginia Mason, which is on the West Coast, under Foster Excellence, the hospital agrees to recruit and retain superior physicians and staff, support career development and professional satisfaction, acknowledge contributions to patient care and the organization, and create opportunities to participate in and support research. Whereas the physicians, in focusing on patients, agree to practice state-of-the-art quality medicine, encourage patient involvement in care and treatment decisions, achieve and maintain optimal patient access, and insist on seamless service. Finally, with Maine Medical Center, under service, the hospital pledges to put patients first in all efforts, to respect the integrity of the physician-patient relationship, and provide resources necessary to support patient and family wellness. The medical staff pledges to put patients first, involve patients and families in care decisions, support and encourage patient and family wellness, and strive for excellent patient satisfaction. The idea of a compact can also be used to teach physicians process skills. As you know, most of us learn in medical school a lot more about outcomes than we do about processes for success. And anybody who's interested in this article is welcome, and who would like a copy of it, is welcome to send me an email, and I'd be happy to send it to them. But this is something that the doctors can use at the beginning of any new meeting, the way to get everybody on the same page. And the advantage of that is if somebody does start criticizing somebody else, rather than point out that this person is out of order, they can say, wait a minute, didn't we all agree to refrain from personal criticism? It also highlights the importance of respecting each member's confidentiality. So what are some tips for successful hospital physician compacts? understand that the goal is a social contract, not a legal contract, to build trust, foster collaboration, and improve patient care. Defines mutual commitments. It sets expectations and responsibilities, and recognizes, we talked about before, that doing this in a bottom-up fashion, the process of engagement is just as important, if not more important, than the content. And finally, one more way that we can engage physicians is to help them find their niche. It's very easy in retrospect to learn how to be a cardiac surgeon or a neurosurgeon or a cardiologist because the path is well defined. 4 years of college, 4 years of medical school, 3 years of residency, or 3 to 5 years of residency, a couple of years of fellowship. But once one gets in practice, all of a sudden it becomes much more diffuse in terms of what to do next. So asking them to write down, what are you really good at? Maybe 5 different bullet points. And then to ask them, what are the benefits that you provide that people pay you to deliver? And then the last thing, ask them to think about the last time they felt really alive and lost track of time. They were so absorbed in what they were doing, whether it was health care or not. And that intersection of those 3 circles may help them become closer to their niche. So in conclusion, as we said, physician engagement is easier to pronounce than achieve because physicians and administrators learn different ways of doing things and need to depersonalize their differences. Understanding that the reason that both of them chose careers in healthcare was to make a difference in patients' and families' lives, and that these common concerns we share provide the framework for a way of improving our collaboration and the clinical and financial outcomes that go with it. People often ask me, so what should I start? Where should I start? And I think it doesn't really matter so much where we begin, provided we start now, recognizing that the status quo is a decision, and build a culture from the bottom up that supports and makes it safe for reflection, inquiry, and dialogue, and involves acting, learning, and adapting so that learning is never seen as failure. And that's the end of my presentation. I'm happy to entertain any questions that have come up. Leanne, do you want to?
I sure will. Thank you, Dr. Cohn. That was great, and I really enjoyed the real-life examples that you were able to give. If you all have questions and answers, we've had several come in already. Please remember to put them in the question and answer box on your right, and I will moderate and give those questions to Dr. Cohn to answer for us. And we'll go ahead and jump right in. You shared a ton of great information. I think we can all learn from your insightful experiences. So we're excited to move into the question and answer period. A couple questions that have come in already, Dr. Cohn, is how can I get my physicians to see the big picture strategy rather than focus on the minutia of the day-to-day frustrations?
That's a great question, and the question for all of us is how do we rise above? I think we all want to be part of something larger than what we are that enhances patient care. And one of the things that I'd like to say is invite them to participate. A doctor in upstate New York said, whenever we're not invited to sit at the table, we feel like we're on the menu. And so inviting them to sit at the table before the major decisions are made rather than to bless the decisions after they're made shows a trust in the physicians and a feeling that they can become owners.
Great, thank you. Next question is, I want our physicians to have some skin in the game with our big initiatives. What do you recommend?
Well, I think you have to ask the doctors, what does it mean to them to have skin in the game? As they say, everybody's favorite radio station is WIIFM, what's in it for me? And sometimes we use the golden rule thinking that just because we want something that the doctors will want something. And Tony D'Alessandro talks about the platinum rule, which says do unto others as they would want to be done unto, which means you have to talk with them and communicate with them and find out what it is that they want. And so once you do that with active listening, you find out that that's key to engagement. And there are 5 different steps that are involved in active listening. One of them is to concentrate fully on the speaker, not try to multitask. The second thing is to listen not only with one's ears, but also with one's eyes, and listening for any sort of idea of tone of voice or anything at all that might be involved, to open one's stance as well as open one's mind. And then the last thing is to empathize with the doctors and try to see things as they would see them. And that's very difficult to do because we've been through different training programs, but the people who do it well can make a tremendous difference in their organizations.
Great, thank you. Next question, Dr. Cohn, is how are the challenges different with so many employed physicians now?
Well, what you got to understand is that employment doesn't necessarily mean engagement. Even though there are contractual responsibilities, doctors' first area of sensitivity or first area of commitment is usually to their profession and then to their colleagues, and very far down the list it's to the place that they work. So I think that there are a lot of things that don't really differ between employed and independent physicians. They all want to make their time count, and I think they'd all like to leave a lasting legacy. So I'd want to hear from them about what they think the differences are between employed and independent before I offered any prescriptions.
Great, thank you. Next question states, I'm a physician, and the big picture initiatives often invade some of my time that I want to spend with patients. How can I communicate this with our leaders?
I think that sometimes what we need to do is understand that anger or overwhelm is a sign of pain. And I think what this doctor is describing is a certain amount of pain. I think what the administrators need to tell them is that the jobs of physicians and administrators are blurring. Think about the idea of hospitals and physicians being penalized for readmissions or hospital-acquired infections. And so it's necessary for the two of them to work together in ways that they haven't before. And one way I get doctors to participate is I say change done by us is usually preferable to change done to us. And I think doctors understand the idea of being involved and being proactive as compared to only being reactive.
Great, thank you. Next question is, I'm more interested in the legal and compliance challenges than in culture relative to physician engagement. What are you hearing in the industry regarding this?
I don't know much about legal and compliance stuff. I leave that to the legal and compliance experts. I think they speak their own language. One of the things that I would say to you is that there's a phrase that culture eats strategy for lunch. And so I think it's very important that everybody be interested in culture. It has a major effect on the success of the legal and the compliance initiatives. And I think anybody in that field would agree with me on that.
Yes, I agree. And next question kind of relates to what you said about the culture each strategy for lunch, which I completely agree with. And that is for organizations that don't have this collaborative culture today, how do you recommend they start to build that while seeming sincere in getting the engagement that they need?
I think that what they might want to do is reach out to some of their best doctors who have earned the respect of other doctors and find out what are the considerations that the doctors would like improvement on, and then to work with the doctors on how to improve those things. If you can find some quick wins like we talked about in that hospital in California, that action tends to increase the transparency and trust. But trust is really determined by actions and not promises. And I think that the administrators need to recognize that the idea of time for doctors is much shorter than it is for administrators. I'm amazed when I travel around the country and I ask doctors to define what's their definition of long-term, and they tell me 48 hours. And that's just because they work with patients where things change very rapidly.
Right, great, thank you. Next question that came in is, what do you see happening to the outliers, the people who just can't get on board with this kind of change and engagement?
I had a professor once who used to quote the Latin. He said, ubi mors, ibi spes. And what that meant is where there's death, there's hope. And there are going to be people who can't get this. Hopefully, there are ways that one can reach out to them. I know one hospital, they've reached out to somebody, and he couldn't really grasp the importance of doing things a different way, but he's passionate about quality, and so he works in the physician peer review area, and he helps in that regard. There are other things that you ask doctors, what would you like to be known for, or what would you like to do, and sometimes you can find ways of helping them transition. One thing that was very interesting was a book written by Weiss about now is a great time to be a physician, and what Dr. Weiss was referring to is that physicians taught other physicians how to embrace electronic health records. And one of the doctors wrote a note to Dr. Weiss, thanking this other physician who helped him, said, I thought I'd have to retire, and this doctor has given me another 10 years with the Kaiser Health System. So maybe we reach out to other doctors who have made those changes and help them bring other doctors along and not see it as a battle between doctors and administrators.
Great, thank you. And one other question that just came in is, Dr. Cohn, we appreciated your presentation. We are embarking on this journey. Do you have any recommendations of where we can find tools to help us with our physicians?
Oh, I'm so glad they brought up the idea of tools, because I asked healthcare administrators one time, what's the image that comes to mind when you think of the word tools for physicians? One of them said a hammer, another one said a chainsaw, and the third said a gun. I mean, that really embodies what I think about tools and physician-hospital relations. I would encourage them to think about what Brian Wong said. He interviewed over 5,000 physicians, and he asked them what really mattered to them. Number one was meaningful work that makes a difference. Number two was camaraderie, and number three was positive feedback at regular intervals. He paraphrased Mark Twain, who said, I could live for months on a compliment. And so I think if we focus on those sort of ways of improving the work and work environment, and also helping doctors make their time count, that might be a better way of doing things. That, to me, is all about the timely execution of strategies and tactics rather than focusing on tools. That's a great question, though.
That was a great question. And then I have one final question here. Dr. Cohn, how long have you seen it take to make a big turn in physician engagement? Are you talking months, years, or a lifetime?
This is a journey, but I think one can start to see improvements within 6 to 12 months if it's done in a focused way, and if people keep the promises and understand that we're all in a learning mode together. In the beginning, this is a little bit like a skin graft that hangs on by just biologic buds, and it takes a while to take, obviously. It's very sensitive to being rubbed off early on. But over time, as the collagen sets in, I think the bonds improve between physicians and hospital leaders. And you get what I call a virtuous circle or a virtuous cycle in which improved collaboration improves revenue, cuts expenses, improves clinical outcomes, enhances recruitment and retention not only of physicians but also of valuable nurses and other allied healthcare professionals, and that improves outcomes, and it continues to get easier year after year after year.
Great, thank you. Well, that was the last of our questions. We're going to wrap up a few minutes early, but I know everyone always appreciates having a few minutes back in their day. Dr. Cohn, I want to thank you for taking the time to share what are real-life examples of being able to make this change given where we're going in the healthcare industry. It was insightful and a great learning opportunity for all of us. For those of you on the phone, if you'd like additional information on how PerfectServe's cloud-based communication system can help your hospital practice or system streamline communications, let us know using the poll feature located on your screen. Also to our audience, we appreciate all the great questions today. We were able to get through all of them, and if you would like to contact Dr. Cohn directly, his email address is on the screen now, and he'd be able to email you some of the articles he talked about. If you enjoyed today's webinar, here's a look at our calendar of future events. These webinars are always free, and links to register can be found at theperfectserve.com by clicking on the Knowledge Center tab. And again, Dr. Cohn, I'd like to thank you for sharing your insight today, and also thank you to our audience for joining in. Please take a moment and tell us how we did, and have a great afternoon. Thanks so much.
Thanks, Leanna. My pleasure. Bye now.